Welcome, everyone. You've joined us for a deep dive today. We're looking at sources you shared about uh, Arginine Vasopressin Resistance, or AVP-R, and also Arginine Vasopressin Deficiency, AVP-D.
Right, and some people might know these by their older names, nephrogenic and central diabetes insipidus.
Exactly. So our goal here is to really unpack these conditions. We'll probably focus a bit more on AVP-D, as the sources suggest it's, well, more common in children.
It makes sense. It's a really important area.
Yeah, so whether you're tuning in for professional reasons, maybe personal interest, or you just, like to stay informed about children's health.
We'll be covering the causes, the mechanisms, how they actually work diagnosis, and of course, management.
Okay, so let's start with the basics, differentiating them. AVP-R and AVP-D, they sound similar.
But they're fundamentally different problems, even though the main symptom, that excessive urination, can look the same initially.
So AVP-R, the R is for resistance. That means the body makes the hormone, ADH, but the kidneys don't.
Listen. That's a good way to put it, yeah. The kidneys have decreased sensitivity to antidiuretic hormone. The signal's there, but the receiver isn't working properly.
And what causes that resistance? It's not the pituitary gland, right?
No, definitely not pituitary related. It can be genetic, sex-linked, autosomal dominant, or recessive patterns.
Okay.
Or it can be acquired, things like chronic kidney disease itself, or electrolyte imbalances like high calcium, low potassium. And certain drugs are quite known for it. Lithium is a classic example, but also amphotericin, methicillin, rifampin.
Right. So managing AVP-R is about working around that kidney resistance then.
Exactly. So you might use diuretics, paradoxically maybe, ensure a really high fluid intake, restrict sodium, sometimes a high-protein diet is mentioned.
And that drug DDAVP, no use here.
Generally ineffective, no, because the problem isn't a lack of ADH, it's the kidney's response to ADH. Giving more won't help if the kidneys can't react.
Okay, that makes sense. So let's pivot to AVP-D. The D is for deficiency. This is the more common one you said.
Yeah, especially in the pediatric population, it's the most common form of this kind of AVP dysfunction. Here, the problem is with the hormone supply.
So the pituitary gland isn't making or releasing enough ADH.
Precisely. The signal to conserve water is weak or absent from the start.
And the hallmark symptoms are pretty intense, I gather.
Oh, definitely. Excessive thirst, that's polydipsia, and excessive urination, polyuria. And the key is, it doesn't get better if you just try to drink less.
Because the body is losing water regardless.
Exactly. The kidneys just can't concentrate the urine without that ADH signal.
Now, in children, what usually triggers this? The sources mention head trauma.
Yes, that's a significant one. Complications from head injuries or after cranial surgery, especially for tumors near the hypothalamus or pituitary, like craniopharyngioma.
Okay, but it's not always trauma or surgery, is it?
No, not at all. It can be hereditary. And interestingly, about 10% of cases in children are idiopathic, meaning, well, we don't actually know the cause.
Really, 10% is quite a bit.
It is. Other causes include specific genetic mutations, granulomatous diseases, infections like meningitis or encephalitis.
Wow, okay.
Vascular issues, congenital malformations, infiltrative diseases like leukemia invading that area, and even some drugs like phenytoin, which can inhibit vasopressin release.
So a lot of potential causes, and the sources emphasize this is often permanent.
Usually, yes. It typically requires lifelong treatment and management.
Okay, let's dig into the why a bit more, the pathophysiology. It boils down to that lack of ADH or vasopressin.
Right, which is normally produced up in the hypothalamus and then stored and released from the posterior pituitary.
And its job is water balance.
Essentially, yes. ADH acts on the collecting tubules in the kidneys, making them permeable to water. This allows water to be reabsorbed back into the body.
Conserving water, keeping things concentrated properly, maintaining normal osmolality.
Spot on. So when you have AVP-D, that deficiency means the kidneys lose their ability to reabsorb that water effectively.
So they just pass large volumes of dilute urine.
Exactly. And consequently, sodium tends to get concentrated in the serum because you're losing relatively more water than salt.
Okay. So how do we treat this? If it's not a tumor you can remove, what's the approach?
The general strategy involves a few things. A low solute diet can help. That means low sodium, low protein.
Why low protein?
It reduces the overall load of solutes the kidneys need to excrete, which can indirectly reduce water loss. But the main treatment is ADH replacement.
Replacing the missing hormone.
Yes, on a daily basis. And the drug of choice for home treatment is usually DDAVP desmopressin acetate.
Right, the synthetic long-acting version.
Exactly.
How is that given to kids? I saw nasal spray mentioned.
Intranasal is very common, yes. But it can also be given subcutaneously injected under the skin or orally as tablets or even buccally dissolved in the cheek.
Lots of options. Does the dose vary a lot?
Oh, absolutely. It has to be tailored based on age, urine output, and urine-specific gravity, how concentrated the urine is. It's very individual.
That sounds tricky, especially with really young children. Infants.
It poses unique challenges, definitely. Infants and small children can't easily access fluids themselves, and they can't tell you they're thirsty.
Right. So managing DDAVP must be complicated.
It can be. And often, in neonates and young infants, the initial focus is just on fluid therapy, ensuring adequate intake. Their drinking is often driven more by hunger for milk or formula than actual thirst.
Okay. Their fluid intake is tied to nutrition.
Pretty much. And because absorption via nasal or oral routes can be a bit variable in this age group, some experts actually suggest that subcutaneous DDAVP, the injection, might be more effective and predictable.
Interesting. What about in the hospital, if a child is admitted?
In the hospital setting, they might use shorter-acting forms of vasopressin, like intravenous aqueous vasopressin or impetressin.
Why shorter acting?
It allows for quicker dosage adjustments. If the child is unstable or they're just trying to figure out the right dose, being able to tweak it more rapidly is helpful.
Got it. So whether it's long-acting DDAVP at home or short-acting in the hospital, the goal is the same.
Reduce the polyuria, reduce the polydipsia, decrease urine output, and burst. And it always requires careful dosed titration.
Finding that sweet spot. I also saw a specific note about the metered nasal spray. Something about the dose needing to be over 10 micrograms.
Yes. For the metered spray formulation, the prescribed dose usually needs to be greater than 10 millisievert per 0.1 millimol for it to be effective. It's a technical detail, but important for prescribers and pharmacists.
Okay. So moving on to assessment. How do nurses figure this out or monitor it? Starts with history, I assume.
Absolutely. A thorough health history is key. Looking for potential triggers, neonatal problems, past infections like meningitis, other conditions like leukemia, any family history.
And you mentioned earlier the onset is often sudden.
Yeah, unlike a lot of endocrine disorders that creep up slowly, AVP-D symptoms can appear quite abruptly. That's a key feature.
And the first things reported are usually
Polyuria and polydipsia, those are the big initial flags. The child's drinking tons and going to the bathroom constantly.
and they usually try to keep up by drinking, unless they're unconscious.
Right, but if they can't compensate enough, that's when you start seeing early signs of dehydration.
What else might parents report?
Frequent bathroom trips, obviously. Waking up at night to pee nocturia. Bedwetting, enuresis in a child who was previously dry.
Okay. And if it progresses or dehydration sets in?
Then you might see weight loss, irritability, which could be from dehydration itself or just the frustration of it all, maybe intermittent fever, vomiting, even constipation.
And the physical exam, what are nurses looking for?
Well, in infants, failure to thrive or weight loss,
Mhm.
obvious signs of dehydration, dry mucous membranes, decreased tears. Urine output is a big one, checking if it's over that threshold, like 3 LMN per day.
Right.
They might also note tachycardia or tachypnea, faster heart rate or breathing as the body tries to compensate. In babies, slightly depressed fontanelles, maybe decreased skin turgor.
Okay, so history and physical point towards it. What about confirming the diagnosis? Labs and tests.
Yes. Imaging first, often. CT scan, MRI, maybe ultrasound of the skull and kidneys. They need to rule out any lesions or tumors causing the problem.
Makes sense. And urine tests.
Crucial. Urinalysis will show very dilute urine, low osmolality, usually under 300, low specific gravity, under 1.005, and often low sodium in the urine.
And blood tests. The opposite.
Generally, yes. Serum osmolality will be high, over 300, indicating concentrated blood, and serum sodium levels will likely be elevated.
Because of the water loss.
Exactly. And then there's the fluid deprivation test. That's a really important diagnostic tool.
How does that work?
You basically restrict the child's water intake under close supervision and see how their body responds. You measure vasopressin release, urine output, urine concentration, and serum sodium.
In an AVP-D, the body won't respond normally.
Correct. Normally, with water deprivation, ADH is released, urine output decreases, urine gets concentrated, and serum sodium stays stable. In AVP-D, that response is impaired or absent.
And the sources had a note about that test.
Yeah.
Kids can get irritable.
Understandably. They're thirsty and not allowed to drink. It's important for staff and family not to drink in front of the child during the test. A small thing, but makes a difference.
Good practical tip. Okay, so diagnosis is confirmed. How is it managed from a nursing perspective? Care plans need to be individualized, I imagine.
Highly individualized, yes, based on the child and the family's response. A huge focus is promoting hydration.
Keeping them balanced, What are the goals?
Usually aiming for an hourly urine output of about 1 to 2 millimoles per kilogram of body weight, and a urine-specific gravity of 1.010 or higher, showing the urine is concentrating better.
And there was an alert about too much urine output?
Yes, a clinical reasoning alert. If urine output exceeds 1,000 millimolars per hour for 2 voids in a row, the provider needs to be notified immediately. That's significant fluid loss.
Wow. So maintaining fluids, monitoring vitals, intake output, daily weights, standard hydration stuff, but maybe more intense?
Pretty much.
Yeah.
And being careful not to stop fluids too abruptly because that carries a risk of hypernatremia and even seizures.
Right, the high sodium.
Exactly. And remembering infants need more frequent feeding due to their specific physiology, dilute urine, higher water intake relative to size, lower vasopressin secretion.
So constant vigilance for dehydration signs, especially when starting treatment or doing tests.
Absolutely. And there was another note about monitoring blood pressure closely when initiating vasopressin treatment, as it can affect BP.
Right. And for kids who can't drink normally, feeding tubes.
Yes, if a child is unconscious or has a brain injury impacting their ability to drink, hydration and nutrition might need to be managed via nasogastric or gastrostomy tube feedings.
Okay. Beyond fluids, what about activity?
It's important to help them find appropriate activity levels. They might need time to regain strength. Scheduling regular bathroom breaks is essential, obviously, and making sure they always have access to fluids they like to drink.
Tailoring the plan to their daily life.
Yes, fitting the treatment into their routine as much as possible.
And then there's the family education piece. That seems huge for a chronic condition.
It's absolutely critical, involving the family right from the start in developing fluid plans. Keeping a daily log or journal can be really helpful for tracking intake, output, medication times, and any symptoms.
Helping them become experts in their child's care.
Exactly. If the child have an intact thirst mechanism, they can often help self-regulate. If not, the family needs support developing a solid 24-hour fluid replacement plan. That might include teaching on NG or G-tube feeding if needed.
And remembering nighttime fluids for infants.
Yes, that's important. Families also need clear education on the signs of both water intoxication, which can happen if they get too much fluid or too much DDAVP.
Like drowsiness, headache, confusion, weight gain.
Right, sudden weight gain, maybe even anuria, which is no urine output. And they also need to know the signs of dehydration, obviously.
Seems like a lot to manage.
It is. They also need a plan for school or daycare, making sure everyone understands the need for unrestricted bathroom access and extra fluids.
And medication administration.
Definitely. The sources mention specific teaching guidelines like Teaching Guidelines 48.1 for DDAVP administration, particularly the intranasal route.
What kind of things does that cover?
Storage, like refrigeration if needed, how to clear the nostrils first, using the measuring tube correctly for the right dose, how to actually administer it, priming the metered spray bottle.
What if they sneeze?
Good question. The guidelines usually advise repeating the dose if sneezing occurs immediately after administration. Also, how to monitor effectiveness using urine-specific gravity and watching for those signs of overdosage we mentioned: confusion, headache, drowsiness, rapid weight gain.
Very detailed. And a medical alert bracelet.
Highly recommended, yes. And regular follow-up appointments, probably every 6 months or so, are crucial for ongoing assessment and management.
Okay, so wrapping this up, we've seen AVP-R and AVP-D are quite different beasts, though they share that symptom of excessive urination.
Yeah, AVP-R is kidney resistance, AVP-D is pituitary deficiency of ADH, and AVP-D is the one we see more often in kids.
Driven by that lack of ADH, leading to thirst, high urine output. Diagnosis involves history, exams, specific lab tests like the fluid deprivation test.
And management hinges on replacing that missing ADH, usually with DDAVP, plus really careful fluid monitoring and a huge amount of family education and involvement.
It really highlights the complexity, doesn't it? Especially in children. And the need for constant monitoring and that partnership between the family and the healthcare team.
Absolutely. It's a delicate balancing act.
It kind of makes you wonder, doesn't it, about, say, future developments in vasopressin treatments or even just the day-to-day resilience of families managing these chronic conditions. What thoughts linger for you, our listener, after this deep dive?
Indeed. Understanding this intricate system of fluid regulation really gives you perspective. Hopefully this discussion has clarified these conditions and maybe sparked some further questions for you to explore.